third annual Idaho Integrated Behavioral Health Network Conference. We're really excited that you're joining us. This is a topic that we have been wanting to provide education and outreach around opioid use prevention and outreach. I'm going to have our two guest speakers and presenters introduce themselves. And if there's any questions, please go to the chat box or unmute yourself. Sam, I'm going to have you take it away on the introductions.
Hi, everyone. Thank you for having me, Jen. It's been always a pleasure to be here. I was at your conference a little bit over a year ago, and I enjoyed presenting there. Had a lot of great questions and follow-up. A little bit about myself for those of you that don't know me. I began my career a very long time ago at The Ohio State University as a registered nurse, as a critical care registered nurse, working in both bone marrow transplant and then transitioning over to the surgical intensive care unit and solid organ transplant. From there, I went into industry and I worked at Bayer and several other companies working with both solid tumor diagnostic imaging as well as acute pain treatments. I've managed to also work on some great projects over the years, one of which with the Department of Defense to replace injectable morphine and hydromorphone on the battlefield with an alternative, which bring me to where I am now as a director of clinical programs at the Elite Provider Network, and I'll have that as my disclosure as well. And Jen and I have had the privilege of partnering on several different projects to take a look at how we can prevent some surgically gated pathways to opioid use disorder. So let me begin my conference by, first of all, naming it. It's the Adults, Hot Topics and Controversies in Acute Pain Management, and trying to take a look at how we can best identify some of the patients at risk for chronic post-surgical pain and chronic use of opioids. Although they're very, very different, as my counterpart, Dr. Karen Boretsky, who will be presenting this similar conference, but from a pediatric perspective in a few minutes. There's subtle differences, big differences in some cases, and we'll be able to identify those throughout these presentations. The objectives that we have for today is to enhance your understanding of post-surgical acute to chronic pain continuum and the impacts of its patients, as well as the total cost. Take a look at the risk factors that are present for chronic post-surgical pain and persistent use of opioids, and try to grab at least an introductory understanding of opioid-sparing multimodal analgesic pathways and medication regimens that are available today. I wanted to take a moment to acknowledge a mentor and also professor, Dr. Eugene Viscusi. He is the chief of pain medicine, a professor of anesthesiology, and the director of acute pain management at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. He's also the current sitting president of the American Society of Regional Anesthesia and Pain Medicine through next year. Disclosures, I already mentioned that I do work for the Elite Provider Network, and I am on the advisory board for Angiotherapeutics. Let's take a look at, defining some of the attributes of what we're taking a look at. Acute post-surgical pain. Let's take a look at a little bit of opioids, a little bit of the social history of opioids in the United States, and then get deeper into some of the specifics of what we'd like to discuss, which is acute post-surgical pain. The most important thing that I want you to take away is that pain is multifactorial. It really breaks down into two general groups, nociceptive and neuropathic. So nociceptive itself breaks down into three general areas, right? Radicular. Radicular is an injury to a nerve. Think of it as a pinched nerve in your back, okay? Somatic pain has to do with your muscles, your bones, and your skin. Think of a headache, cuts, bruises, things like that. Visceral pain has to do with your organs. Aches, the pain can be vague, non-specific. It could be, think of heartburn, think of menstrual cramps, think of, pain which is internal, sometimes reflected in different parts of the body, but visceral is exactly what it means, organ pain. Some of the mediators don't have to be traumatic. It can be an inflammatory process. And normally trauma and inflammation go hand in hand, but not always. And that can be a muscle spasm component. Neuropathic is damage to the nerve, all right? Plain and simple. It can have a normal and abnormal pathways. Typically, when you have an injury to a part of the body, the nerves fire, they send the signals from wherever the injury occurs to the brain. It becomes an abnormal pathway when it gets looped up, and then the pain is sent back down from the brain. And those types of pain can be constant. It can come and go. Think of, the normal pathway would be, think of diabetic neuropathy, pain in the feet, all right, and multiple sclerosis. Those are typical normal pathways for neuropathic pain. I hope this all makes sense to you. And I do hope that we'll have a chance to meet again under better circumstances and have discussions like the ones we had the last time. The most important thing I want you to take away is that when you have multifactorial pain, opioid monotherapy is ineffective within that context. That's probably one of the biggest things that Dr. Viscusi always wanted to make sure came across during one of his presentations. And I want to make sure that you try to understand it. We'll do a little bit of a deeper dive with that as we move forward. Post-op pain has some unique componentry, right? It could be neural, humoral, and combined with emotional events. Those events can amplify or diminish, perception, right? So neural, the injury to the nerve. Humoral, chemically mediated inflammatory response. Emotional events, we all know that there's some, maladaptive brain modeling that can take place, emotional components, anxiety that can be transferred from one person to another. But also, there's also a component of induced hyperalgesia, which we'll talk about here in a few minutes. So again, multifactorial. But let's talk a little bit about the social history of opioids. And this is where the conversation can get a little bit fascinating. And it's really interesting to just really absorb this. So I just want you to take a minute and think about this, right? Are we an opioid-focused society? There's no right or wrong answer. It's just something to consider, right? And is our perception of opioids as a powerful painkiller misplaced? Does it solve all the problems, really? Or does it maybe, with the hopes or misunderstanding of what type of pain opioids are for, do we perceive it as either overly effective, ineffective, a root of problems, and so forth? Those are just things to keep in the back of your mind, right? What's our perception look like? And it's a question for each of us to ask ourselves. Let's talk about opioid use in the United States. In the United States, we have 5% of the global population, but that 5% of the global population consumes almost 90% of global opioids per year. Healthcare costs for opioid abusers are 8 times higher than for non-abusers. Primary care prescribers are close to about half of all opioids prescribed. And the abuse of prescription opioids alone generates $76 billion in 2017 for healthcare related costs. They also, opioid abusers have a higher rate of early termination of care. They sign out AMA, and nearly 80% of heroin users reported, misusing prescription opioids prior to moving on to heroin. So, all these facts we kind of know, but some of the numbers are new, especially that 5% of the population consuming 90% of the global opioids. But also, let's take a look at this. The HCUP database, right? The Healthcare Cost Utilization Project. Here's some of the information that comes out. And I want to just take a little bit of time here to put this slide into context because it really has a lot of great information. right? We already know that opioid abuse or dependence had a higher 30-day readmission rate, 11.1 to 9.1%. The readmissions, the three general categories for the majority of them were infection, opioid overdose, and acute pain. Think about that for a second, all right? The infection rate, 27 versus 19, that's a 30% higher rate for infection. Why? Right? We're going to talk a little bit more about that. Opioid overdose, 10 times higher. Acute pain, twice as higher. Why? There's two of those that I really want you to keep in the back of your mind as context. The 30% higher infection rate and twice as high acute pain. All right, there's very, very specific scientific evidence-based reasons, rationales for those two specifically. And, let's take a look at this. Surgery as a gateway to preventable what? Opioid use disorder, chronic pain, addiction. Let's put it in context, because opioid use disorder and chronic pain are two very different things. But let's see how there might be an association, because again, they're different, but opioid use disorder, right? Surgery gated patients, there's about 40 million surgeries annually exposed to the risk of addiction. And what Dr. Brummett found was that 6.5% of all these patients typically can become persistent opioid users, and about 670,000 will develop opioid use disorder or addiction. Surgical prescriptions account for over 1 billion leftover opioids a year. How many of us have had a surgical procedure and then we're done taking our medication, or we don't want to take it for whatever reasons? I don't want to be addicted. I don't feel good when I'm taking this. But we save them just in case we get hurt again, right? And they stay there, and they stay there, and they stay there, right? 55% of people who misuse opioids obtain them from family or friends who have excess pills, right? And a review of 6 studies showed that 67 and 92% of patients reported unused opioids after surgery. So think about that as a pathway. This slide's a little bit busy, but what I want you to take away from this is that regardless of whether the surgery is minor or major, what Brummett found is that there's a consistent range there between 5 to 6.5%. And I want you to keep that in mind, because we're going to be revisiting some of Brummett's data here in a little bit. But here's the takeaway, all right? And here too is something really important, right? Each day of opioid use increases the risk of 1 year. So again, each day of opioid use increases the risk of use at 1 year. And what I want you to notice is that the delta occurs at 3 to 5 days. And every day beyond that, the risk increases, up to, if at 40 days, about 40%, there's a 40% probability of use at 1 year. 40-40, it's pretty easy to remember. It's actually a little higher, but 40-40 is easy. Does that make sense? I hope it does to you, because that is why certain states are already passing legislation of limiting opioid prescriptions to 5 days or even 3 days. But yet, even with that, even with knowledge, and this is good, solid data that's generally well accepted. We have conversations with practitioners who say, I do really great. My pain control for my surgical procedures are outstanding. I never give my patients more than 30 days worth of opioid pills. And you have to sit there and think, in their mind, they're right, because it's their practice and it's what's worked well for them in the past. Shifting that is where our challenge lies. And one of the places where we can do that is, primary care generally refills the scripts, although people are averse to doing that now because of some of the history that's occurred. But a primary care intervention within 7 days is really a great way to make sure that we can shift from opioid use to non-opioid, pain-specific multimodal analgesia. And we're going to talk a little bit more about that later. How do we identify, and can we identify patients at risk for chronic post-surgical pain? There's multiple factors, but there's things that really are consistent when you take a look deeper down. And that basically, who are the patients that are more than likely to, fail routine care? Anxiety, fibromyalgia, and this has been two factors that have been found to be contributing. Pain catastrophizing, we see that. We see that in people that, having a higher than anticipated emotional response to the perception of pain before it happens. All right, and sometimes during and after, because when you do it before, it will amplify the perception of pain in the future. But there's some things that can be done to try and limit that. Some patients require extended post-op pain management and follow-up intervention, especially with opioids. And opioids are more than likely not going to be the solution. Some overlap of risk factors have increased acute pain and chronic post-surgical pain as well. Let's talk about fibromyalgia and postoperative pain. In a study by Brummett on 500 total joint arthroplasty patients, phenotyped with self-reported pain questionnaires, fibromyalgia survey scores, the higher the scores, they were significantly and independently predictive of an increase post-operative opioid consumption. Age, pre-op, opioid use, overall body pain, anesthetic type were also predictive of opioid use post-surgically. Differential opioid tolerance and opioid-induced hyperalgesia. Remember that slide a little bit earlier? People, one of the factors that was for readmissions was, acute pain, and that was, twice as high as normal for opioid use disorder or persistent opioid users. Opioids have been found to, lower the tolerance and create something that we call opioid-induced hyperalgesia. Opioids produce dose dependence, tolerance, and hyperalgesia, and have a greater respiratory depression at the same level of analgesia versus naive patients. High-dose intra-op opioids are also implicated in higher levels of post-op pain and opioid requirements. But here's one thing that's really important, and that's why I bolded it. But Hayhurst found that, opioid-induced hyperalgesia can occur in the perioperative period when opioids are administered during surgery. So in other words, by administering opioids, which is routinely done under general anesthesia, it's likely that the pain, amplification can occur, in the postoperative, in the immediate postoperative, and certainly in the first few days that follow. And something to think about. Let's talk about the spectrum of post-surgical pain. What's the difference between normal, severe, prolonged, and chronic? It has to do with time, right? Normal postoperative pain and healing is just a matter of days, a few days, 3 days, 3 to 5 days. It's predictable and responds to standard therapies. If you're not familiar with ERAS, enhanced recovery after surgery, it's relatively new here in the United States, but it's actually been around in Europe for about 20 years. And what they found is certain things that we, for example, being MPO prior to surgery, with ERAS techniques, ERAS protocols and processes, patients are generally receiving some type of nutritional loading prior to surgery, immediate ambulation. It's not very hard It's also not very consistent yet. Everyone says that they do ERAS, or a lot of people say that they do ERAS, but there's really no one specific way. So it's really hard to narrow it down as what's best or what's um, evidence-based best practice. Severe acute pain. This is when it goes beyond a few days and it goes into weeks. There's multiple drivers, potential risks of long-term opioid uses can occur here. And there's also a benefit from identification and specialized management. This is the time to make the intervention to try and shift them before it goes on to prolonged pain at weeks and months. Here's where the transition to potential chronic pain occurs. And it's also a high risk for long-term use of opioids. And of course, once you get to months and years, you're in the chronic phase. And this is where different pain descriptors begin to come into the process. There's maladaptive brain modeling. There's a lot of different factors that contribute, but this is where response to multiple drivers become more difficult to implement. I wish I can ask you if there's any questions. I always enjoy the engagement with the audience, and this is a little different. So let's talk about chronic post-surgical pain, some of the neural pathways that take place. Surgery is trauma, right? The pain directly ascends through the neural pathways to the brain. It can be visceral or cutaneous, right? When you injure, especially to the gut, right? That tends to be very, very painful. Chronic post-surgical pain, there's an NMDA descending inhibitory pathway. Chronic pain, and it's commonly referred to as a wind-up loop. And I will let Dr. Boretsky, who follows my presentation, hopefully address this a little bit better, because she is a master at this, and I have a general understanding. But this is when the pain signaling doesn't come from a point of injury. It comes from the brain, and it's a descending pathway, as opposed to an ascending pathway where you have an injury to your hand. The signaling goes up the nerves to your brain, and this is where there's pain in the hand, but there's no apparent trauma because the signal is going from the brain down. Chronic pain following surgery, can we change the outcomes? That's why I have this, please close the gate. You can walk around it very easily, right? What are some of the things that can be done to change some of these outcomes? First, let's understand a little bit better about the incidence of chronic post-surgical pain. Following an amputation, it can be from 30 to 81%, and this is described as pain that is severe and goes beyond 3 months. C-sections, 15%. A chole, 3 to 56. And the thing about chole is that it's my understanding from one of the physicians that I've worked with in the past, Alex Becker at Rutgers. He thinks that chole pain is very easy to manage, and he has a couple of things that he does to help manage that well. Hernia repair. Hernia repair is one of the more common surgeries in both pediatric and adult patients. 3 to 35% have moderate to severe pain beyond 3 months. Mastectomy, no fooling. That's painful, male or female, and something to keep in mind there. 20 to 50%. Look at that compared to hip replacement, or even thoracotomy is high as well. Factors associated with chronic post-surgical pain: nerve injury, inflammation, intense acute postoperative pain. Kellett, one of the things that's really important here is that we take a look at two very distinct avenues for pain: nerve injury and inflammation. Nerve injury tends to be mechanical, or it can be chemical, but inflammation tends not to be mechanical, although it can follow a mechanical injury, but it is a chemically mediated prostaglandin response to an insult. And inflammation can be just as painful as nerve injury. Karen has a much better slide than this, and we had a discussion about this a couple days ago. But effectively, the biological how. If you take a look towards the bottom, here you have a surgical nerve injury. Signal travels up, goes up through the spinal cord, through the limbic system, to the cortex of the brain, and that's how we understand what's going on, all right? But there is another descending pathway that can take place, but let's focus right now on the ascending pathway, which is pretty much, fairly easy for us to understand. Now we're going to take a look at what are some of the pre-op risk factors. The pre-op risk factors is, for example, acute on top of chronic pain. You've already had chronic pain taking place, and now you have an acute injury on top of that. Prior injury, especially a prior injury in the same area, right? Or a comorbidity that exacerbates either the injury or perception of pain. And young females tend to be at higher risk for pre-op and post-operative chronic post-surgical pain. There is a genetic component to it. It's been studied by Tremblay. However, maybe that's another one I should also pass to Karen. But there is a genetic component, and that's really what we want to take away from this. Risk factors for developing persistent post-operative pain. Again, very similar. Pre-existing pain, preoperative opioid exposure, genetic component, psychological factors. Please keep that in mind, especially when you get to the pediatric portion of the presentation by Dr. Boretsky coming up. Pre-op pain questionnaires and quantitative sensory testing has found that, several combinations of these pre-existing conditions on the pre-op factors have been associated with enhanced perception of pain and prolonged perception of pain as well. Post-op factors, the intensity of the acute post-operative pain to begin with. The degree of nerve injury. Degree of nerve injury, sometimes think of it this way. When surgery is planned, there can be a greater degree of detail. They cut the nerve, they number it, they re-anastomose those nerves very carefully. It's very meticulous. Compared to a traumatic surgery, someone receives an acute abdomen insult, they have to get to the source of injury right away because there's a perforated bowel. That tends to be emergent, and they just cut through everything to get to the problem quickly in order to have to mitigate all the complications that take place from the injury. So the degree of nerve injury from the surgery, immune activity, all right, inflammation, also immunosuppression, right, infection. Intraoperative high doses of remifentanil have also been associated as a post-op factor in enhanced pain. This is a very, very busy slide, but a working group, put together by Overton, took a look at what the predictive range of oxycodone in opiate-naive patients on discharge after selected procedures. And what you can see is that the range always says 0. It begins with 0, right? And then they're trying to limit it to 10 to 20 pills. And that's an idea. The panel members included surgeons, surgical residents, pain specialists, and nurse practitioners, a few patients, as well as pharmacists. But the idea was to take a look at what we can do as far as prescribing goes. And it's been adopted well in some areas, and in some areas not so well, as we're all pretty familiar with. So opioids, is it our friend or is it our enemy? Think about that for a second. The benefits, is it a potent analgesic? What does that mean? A potent analgesic for which type of pain is what I ask you to take a look at. Is it titratable within a wide range? Does it have no ceiling effect? The more you give, the better it works. Moore's law, as some people call it. Common side effects, GI side effects, gastric paresis, respiratory depression, sedation, confusion, mental status changes, risk of falls, hemodynamic impact as well. It's a powerful vasodilator. Sometimes that's a benefit. So sometimes what I want you to take away is things aren't always as they appear. I love this little slide right here. Glenview Farms, ultra pasteurized non-dairy creamer. First ingredient is milk. Sometimes things aren't what they look like. Because here's what we do know. With opioids, there is an apparent ceiling effect in many patients. There's little evidence to support that more than 100 milligrams of morphine a day does anything better than less morphine. And there's little evidence to support extended release or long-acting formulations work better. Opioid tolerance is a higher incidence of those, as well as opioid-induced hyperalgesia. Some of these topics will be repeated, but they're being repeated for a reason. I want these things to really sink in with you. Chronic exposure generates a state of increased pain sensitivity, which altogether leads to abuse, misuse, and diversion. The risk is much higher than we thought. And with short-term post-op exposure, it can still happen, but hopefully we'll be able to reduce that a little bit. There's a couple of really interesting books that Dr. Viscusi likes to bring up. One of them was put together by Dr. Shem in his book, House of God in New York. And the 13th law, the delivery of good care is to do as much nothing as possible. Think about that for a little bit, because what Dr. Viscusi said is a lot of this opioid crime is a result of trying to do too much to match unreasonable expectations. Hey, you know what? We're gonna have that pain, perfectly under control. You're gonna be very comfortable. As opposed to, you know what? It's surgery, it's gonna hurt. We're gonna try and do our best to take the edge off, but it's still gonna hurt. I want you to focus on working through it. And we're gonna work through it together. Setting the right context. I'll give you a perfect example from practice. The pulling of chest tubes following coronary artery bypass graft. What I would notice is when the physician came out to pull those chest tubes, the mediastinal chest tubes, there are usually 2 or 3 of them. And the doctor would say, this is gonna hurt a little bit. It's gonna be like a bee sting. And they would be pulled, take a deep breath, breathe out, they'd be pulled. And there was so much pain there that, I would often joke that I'm gonna have to peel the patient off the ceiling, but physiologically, the patients were heavily invasively monitored. You can see all these physiological responses to the pain of pulling those chest tubes. One day, I just thought to, ask the doctor, don't tell him it's gonna be a bee sting. Tell him it's gonna hurt a lot. And we joked about it a little bit. He said, what, you want me to tell him it's gonna be like a shark attack? And I was like, well, you figure out what works good. But he basically told another patient that it was gonna hurt quite a bit. And, I want you to do the best you can to relax, but it's gonna hurt a lot. And when he pulled them, I will tell you that the physiological response that I saw on the monitors were far less than they were when they told him it was only gonna be a bee sting, and the pain was actually much greater than what they anticipated. But if you let them know that it's gonna be painful, their perception might be. What I can tell you is that that physician started saying that. He sometimes joked that this is gonna feel a little bit like a shark attack, it's gonna hurt a lot. But it's gonna be short duration and you're gonna feel better soon after that. And what I observed consistently with the patients that I cared for was that the physiological response was dampened substantially. So much so that Dr. Riley at Ohio State, who was the chief of anesthesia, we started aggregating data and he wrote an article on that. Another really interesting book from Sam Quinones from the book Dreamland is the patient is entitled to reasonable attempts to relieve pain by reasonable measures. Set the right perspective. Don't let them know that we're going to take care and eliminate all their pain. And one of the things that Dr. Loser who is one of the chiefs of neurosurgery at Seattle. I'm not sure if he's still there right now, but he said, you are not entitled to pain relief any more than you're entitled to happiness. So really, how we communicate the perception and the context of pain is just as critical as the pharmacology that we use to manage the pain. Perioperative opioids, they contribute to higher post-op opioid use and poor pain control. These are concepts that are generally well accepted today. It contributes to chronic opioid use and abuse, and don't reduce the chronic post-surgical pain to the point that we would like to see. Anesthetic management of general versus regional anesthesia can also make a significant impact on both short-term and long-term outcomes for surgical patients. So some of the takeaways I'd like for you to really grasp for today is that opioids do contribute to hyperalgesia, escalated medical management, and can result in chronic post-surgical pain in approximately 6% of the postoperative patient population. That's very well published, very well documented by Dr. Brummett, who's done extensive research on that. And his findings are that approximately 6% of all adult, 4.8% of pediatric, minor like major surgeries, including third molar extractions, resulted in chronic post-surgical pain. The probability of continued use of opioids increases dramatically on day 5 of use. Please absorb that. Think about that. What can we do? All right. Talk to Jen Y about that. She has a lot of really good ideas. Primary care physician follow-up is critical at that point to transition the patient to non-opioid multimodal analgesia. Let's figure out exactly what's going on, what's the source of the pain, and treat it with the right medication regimen that's not necessarily opioid-based. Opioid-free surgery is a reality. Carolina's Medical Center is doing, opioid-free total joint arthroplasty, shoulders and knees, and they're trying to explore how they can do that with hips as well. And then in Dr. Viscuzzi's backyard, literally across the street and throughout Philadelphia, the Rothman Orthopedic Institute, they abhor use of opioids, but they practice opioid-sparing multimodal analgesia, as their primary pain management technique. Additional takeaways is I want you to understand that for acute post-surgical pain, it's multifactorial. Pick the right medication to address it. With neuropathic, opioids don't work very well. Dr. Viscuzzi likes to use pregabalins and gabapentinoids. For inflammatory pain, NSAIDs, COX-2 inhibitors. When using COX-2 inhibitors, it's good to pick a COX-2 that is highly selective and remains highly selective with dose escalation. Meloxicam is one of those. Acute pain, multimodal with short-term opioid rescue therapy. The ASA recommends that you treat with non-opioid modalities first. Implement all the other techniques, guided imagery, relaxation, breathing, and then if all else fails, supplement with opioid therapy. The way that's a pyramid, right? But we do it the other way around. Opioids first, everything else after. For chronic pain, interrupting the wind-up cycle is a possibility with ketamine and lidocaine neural block infusions. But what's important to understand this, lidocaine only lasts for 4 to 8 hours, maybe a little longer if you combine it with some epinephrine. What I want to take away, and this is something that Dr. Boretsky really drilled into me at one time, was the physiologic effect outlasts the pharmacologic effect. In other words, a drug only lasts for the physiologic response far outlasts the pharmacologic effect. Keep that in mind. Again, ASA guidelines, it talks a little bit about what we talked about here. Multimodal analgesia, and at the very bottom or as you work your way down, take a look at opioid use. opioid prescription. All right. And it says prescribe 5 to 7 days of the smallest dose of immediate release opioids. If pain is controlled, continue with non-opioid medications. If pain is uncontrolled, consider an intervention. All right. Choosing wisely is an arm of the Board of Internal Medicine Foundation, where they try and take a look at what are ways to educate the public, employers, payers, and providers on some of the best practices and encourage an ongoing dialogue to see what we can do. I've met with them, I've talked with them, and one of the things that we're working together on is how we can develop a platform to engage people to what are the 5 questions you need to ask when you have pain following surgery. Improving wisely is from the other side, from the physicians. What can physicians do to advance high value care and lower costs by improving processes and prescribing techniques properly? All work together as a care team in order to achieve that. So with that, I wanted to thank you. And oh crap, was that today? So the boat didn't sail and leave us behind. Actually, what it does is it gives us the opportunity to really sit back and think of some of the things that we talked about today, develop good questions, enhance our dialogue, and come up with better ways to do that. I want to thank all of you for spending some time with me today. And I hope there is a way that Gen Y could find to maybe funnel some questions to us that we'd be more than happy to follow up on and get back to you with. And with that, that concludes my presentation. I hope all of you got at least a few pearls of wisdom from it. And with this, we're going to segue to Dr. Karen Boretsky's presentation coming up shortly. Thank you.
Recording is on.
Okay. Hi, I'm Dr. Karen Boretsky. I'm a pediatric anesthesiologist at the Boston Children's Hospital. I initially did my training in anesthesia and critical care at the University of Pittsburgh. I did my fellowship in pediatric anesthesia at the Children's Hospital of Philadelphia. I practiced in Pittsburgh for many, many years, where I learned special techniques in regional anesthesia, and most recently have moved up to the Boston area at the Boston Children's Hospital, where I currently practice. My passion is taking care of children and trying to improve their care, and my subspecialty really is in opiate-free anesthesia, using regional anesthesia as a foundation for better pain management. And I want to thank the Idaho Integrated Behavioral Health Network for inviting me to speak today. And I can't advance my slides.
Just hit your PowerPoint. There you go.
I just have to hit the, okay, all right. Okay, anyway, so this is who I am, Karen Boretsky from the Boston Children's Hospital. And what I want to do is I want to really follow up and develop some points that Sam Reiga talked about. And that's going to be to help facilitate the understanding of some of the concepts of post-surgical acute pain management in children, understand some of the risk factors for chronic post-surgical pain and persistent use of opioids, and understand how we can avoid opiates using multimodal analgesia and trying to improve care. So what I'm really going to focus on is two, what I believe are emergingly apparent gateways to opiate abuse disorder. And the first is the improper treatment of chronic post-surgical pain using opiates, and the gateway of perioperative exposure to opiates via surgery in pediatric patients. And I believe that these are two very important, unappreciated gateways to opiate abuse disorder. I'm going to start first by talking about chronic post-surgical pain. This is chronic post-surgical pain is a phenomenon whereby after surgery, after a surgical procedure, a patient develops a chronic pain syndrome. And although it's been around for a long time, it was really best described and presented by Crombie and his colleagues in 1998. And the definition is that this is new pain that lasts greater than 3 months after a surgical procedure. It's not associated with some pre-existing problem or a post-operative complication. And in fact, it occurs in 10 to 50% of adults. And I'm going to present some data in children. It occurs in 20 to 22% of children and is stratified by the type of surgery that's being performed. And in the adult population, as described by Crombie, it's associated with functional disabilities, poor sleep, missed work days, depressive symptoms, and things that really affect economic factors and as well as psychological enjoyment of life kind of factors. So since Sam already presented the post-op pain in adults, I'm just going to try to focus in on some of the unique aspects in pediatrics. And they're, just as in adults, there are neural, humoral, and emotional components. And post-operative acute pain is a combination of the surgical trauma with neural disruption and the inflammation of the surgery itself. And one of the things, increasingly we're working towards minimally invasive types of surgery. And understand that minimally invasive does not equate to minimal pain. And in fact, in many of the minimally invasive surgeries, the pain post-op is equivalent to the pain that we saw associated with the open procedure. So this is something that we have to be aware of when we sort of, are dismissive and say, oh, it's just a laparoscopy, it's just a thoracoscopy, etc. Kids have different kind of brain modeling capabilities and have the same sort of maladaptive track that we can see them get into. And opiates also can cause problems with immunity. Opiates are immune suppressants, and opiates also induce hyperalgesia, as Sam described in the last talk. And with kids, the one thing that's unique is that the parents' behavior is a very, very powerful influence on the way children perceive and experience pain. So I want to focus on who are the at-risk populations. And there's some intraoperative risk factors for chronic post-surgical pain, the surgical procedure, and we do see that open procedures versus non-invasive do tend to be higher risk for chronic persistent surgical pain syndrome. So a laparoscopic chole, a laparoscopic hernia versus their open counterparts. Surgeries where there's nerve ligation tend to be higher risk. And in fact, the type of anesthesia that we provide as anesthesiologists can also influence the development of chronic post-surgical pain. And we find that high-dose intraoperative opioids, rather than being preemptive, tend to produce hyperalgesia, and the use of high-dose opiates intra-op is associated with hyperalgesia post-op and a tendency towards chronic post-surgical pain syndromes. And in a poorly understood phenomenon, we also see that patients who receive general anesthesia have a higher risk for chronic post-surgical pain than those patients who undergo regional anesthesia, such as spinal anesthesia, epidural anesthesia, or simple nerve blocks. So those were the intraoperative risk factors. Some of the pre-surgical risk factors are younger age. And so we see in the adult population, 65% of those patients less than 50 develop chronic post-surgical pain versus only 40% of those who are older than 50. Females develop it more than males. Those patients who are pre-surgically experiencing ischemic pain on preoperative opioids, or those who have preoperative pain syndromes, are at higher risk. And the one thing that we have a lot of control over, and I'll spend some time on, is the intensity and duration of post-surgical pain is a big factor in predicting chronic post-surgical pain. Poorly treated acute pain tends to lead to chronic post-surgical pain. There are psychosocial factors, those patients who are more anxious, who catastrophize pain, those patients with psychiatric depressive symptoms tend to go on and have a higher incidence of chronic post-surgical pain. And interestingly, there's no relation to socioeconomic status. There is likely a strong genetic component. We found this in mice. It isn't well defined in humans yet, but we believe that in the future research is going to define certain genetically predisposed populations. So I'm going to talk a little bit about the chronic post-surgical pain, and there's some terminology that needs to be defined. And modulation, these are terms that apply to the brain and sort of brain learning and brain changes. So neuron activity can be modulated, which means it's a reversible change. And this is something that follows repeated excitation of the peripheral nociceptors. Modification are long-lived, irreversible changes. Neuroplasticity are those changes that actually occur in the hardwiring in the neural architecture. And so modulation is reversible changes, modification are long-lived changes, and modification can lead to long-term neuroplasticity changes in the actual architecture of the brain. And we talk about sensitization, and sensitization can be peripheral sensitization or central sensitization. And central sensitization is really what we're talking about when we're talking about chronic post-surgical pain syndrome. So here's an oversimplification of the pain pathways. They're basically almost like thousands of separate pain pathways that can be modified and activated, modulated, modified. But there are 5 main ones. And if you look at your peripheral sensory nerve, there's pain signaling that goes out via the peripheral nerve that hits in the spinal cord. It's conducted from the spinal cord up to the central nervous system in the brain. It bounces to some of the gray matter in the brain. And then the experience of pain results in activation of the descending pathways. And this is normally an inhibitory pathway that can be modulated. And this is where we start to see windup. So the experience of uninterrupted pain results in the unmodulated release, if you will, of this otherwise inhibited pathway that just causes windup and exacerbates any experience of pain. I want to point out that in addition to the hardwiring here in the signaling along the peripheral nerves, there's also inflammatory signals that that once you make any cut or any any disruption of human tissue, of tissues, can result in the release of inflammatory factors. And this is something that isn't, in fact, blocked with nerve blocks or even morphine. These inflammatory signals are what we're targeting when we're targeting the drugs, non-steroidal anti-inflammatories, and drugs like Tylenol. And so, just with that as a background, I really want to talk about chronic post-surgical pain and how it's unique in children. And you might say, well, first of all, is it even a problem? And 5 million children have surgery every year in the United States. And Dr. Jennifer Rabbits from the University of Seattle at Seattle Children's is one of the people who does a lot of research in this, and has been able to define some of the financial cost and penalty that we're paying for chronic post-surgical pain in children. Remember, children have a longer life to live. When we're talking children less than 17 years of age, any impact on their quality of life, their ability to be productive, is a more long-term burden for society. And so Dr. Rabbits, in talking about this 5 million surgeries a year, has come up with the $20 billion being the cost burden of society for the treatment and just the enduring pediatric chronic pain. And this was her data here. She did a meta-analysis. She looked at all of the studies that were out there looking at chronic post-surgical pain in children, and she looked at major surgeries, and she found a median prevalence of chronic post-surgical pain in children after major inpatient surgery of 20% at 12 months post-operatively. And she looked at the different predictors. She looked at age and sex, and found that, in fact, unlike the adult population, age and sex were not predictors of chronic post-surgical pain syndrome in the pediatric population. What she did find was associated with chronic post-surgical pain syndrome in children was pre-surgical pain. So those patients that came to us already on opiates, those patients who came to us already suffering, tended to have more refractory pain in the postoperative period and were more prone to this modification and modulation of the pain signal to go on and create chronic post-surgical pain. We found that children with poor pain coping skills had more chronic post-surgical pain. Those patients that had more anxiety. So they can have poor coping skills and also more anxiety, and the two put together were really a devastating combination. And what's really interesting, and we don't see in the adult population, is the effect of parents on the development of chronic post-surgical pain in children, and that's parental catastrophizing. So if the parents are hovering over the child saying, oh, honey, does that hurt? How much does it hurt? Oh my God, let's get your nurse in here. And that kind of parent behavior and the parent anxiety and the parent catastrophizing was really one of the strongest factors associated with the development of chronic pain syndromes in children. It was not associated with child catastrophizing, other than if the patient had poor pain coping or child anxiety, but the catastrophizing alone was not enough without the overlay of parental catastrophizing. Family income wasn't a factor, nor was the mood of the patient. And to dive sort of deeper into, well, what kind of parental behaviors really do play into the pain syndromes in children, researchers have looked and found that 2 weeks prior to the surgery, if the parents had disruptive sleep and high anxiety, that was the strongest risk factor for the development of pain syndromes in children. And so that was major surgery. And so say, well, you know, very few children have major surgery. A lot of kids, you know, just having outpatient surgery, surely that can't be a problem. And there really haven't been good studies looking at minor surgeries in children. And in fact, 2 million children a year have surgical procedures performed as outpatients. And let's just take, for example, you know, 625,000 inguinal hernias performed per year. And my colleagues and I looked at a database. We had 300 and some children, and we looked at, we followed them for 6 months post-op. And some of the surgeries that they had were really bread and butter common surgeries that children undergo every single day. Orchiopexy, inguinal hernia, hypospadias repair, various orthopedic surgeries, both traumatic and congenital. And these were you can see here, these were the numbers of patients in our study. Most of them had orchidopexies. A large number, 87 children, had inguinal hernias. And combined orthopedic surgeries here in excess of 50 some cases. And what we found was that the gray bar here is pain at 1 month, and the black bar is pain at 3 months, and the dark gray bar is pain persisting at 6 months post-op. And here you can see that with inguinal hernias, orchidopexies, across the board, a significant number of these children were still experiencing pain at 1 month. And this really surprised us that if you look at hernias, 1/3 of these children are still complaining of pain at 1 month follow-up. Again, 1/3 of hypospadias, orthopedics, and overall, it was 24% of patients. We saw pain decrease then over 3 months and 6 months in a stepped fashion, but found that 9% of those patients having inguinal hernias were still experiencing persistent pain at 6 months, contrasted with 2% of orchiopexies, 5% of hypospadias, and only surprisingly 2% of orthopedic. And we had originally speculated in our hypothesis that orthopedic surgeries are more traumatic and would result in a higher instance of chronic pain. So this was in fact sort of an interesting finding. Overall, children are experiencing, after minor outpatient surgeries, a 4% instance of chronic post-surgical pain at 6 months, with those undergoing inguinal hernias having the highest number. And so we looked at the various predictors. We tried to look at inguinal hernia was associated with increased post-op pain. We didn't find that post-operative pain scores in the recovery room were associated. We didn't find any age association. What we did find was that those patients who were experiencing pain at 1 month, if you had pain at 1 month, 13% of those patients continued on to have chronic post-surgical pain. If you were not having pain at 1 month, you only had a 1% risk factor of going on to have chronic post-surgical pain. And the conclusion that we came to based on this was that more aggressive follow-up is needed, and more education of healthcare providers to understand that kids with inguinal hernias do need to be followed up, can present with long-term problems, and that those patients experiencing pain at 1 month need more aggressive follow-up or continued follow-up in order to prevent those kids from going on to have chronic post-surgical pain. Now, I can say in terms of treatment, let's go back for a second. In terms of treatment, I'll talk a little bit about treatment later. We really don't have good studies on what is going to be the best treatment, but getting this pain under control is going to be very important. If you want to look at the models and just wonder, is it just something that's unique to surgery, or is it an acute pain process? We find that there's a study that looks at traumatic musculoskeletal pain in basically adolescents, those children ages 10 to 17, with follow-up at 1 month and then subsequent follow-up at 4 months. And it was surprising to find that 35% of those adolescents still had chronic persistent pain at the 4-month mark. And their predictors were female sex, those patients who had a psychiatric comorbidity, especially depression, and those patients with poor coping skills. And so this does correlate with the development of chronic pain, that morphing of modulation of the pain cycle to irreversible modulation. And what you see, it isn't just, that the kids are having pain, but this goes on to manifest itself as greater functional disabilities. The kids don't participate in sports. They don't integrate well with their friends. They have interrupted sleep patterns, which really can become a lifelong problem. There have been studies looking at the chronic post-surgical pain, which we believe by all indicators is neuropathic in etiology. And so from what Sam told us about neuropathic pain, we know that opiates as a single treatment is lousy. It just doesn't work at all for neuropathic pain. And so what we need to focus on is the education of the family on the etiology of this chronic post-surgical pain and our ability to treat it. And you have to educate the family and do interventions to decrease anxiety behavior, increase understanding, sort of advance better acceptance of expectations. And going into surgeries, patients also have to understand that there is going to be pain associated with the surgery, and that they have to have reasonable expectations. Once we see the chronic pain syndrome start to develop, it's very important to get anti-neuropathic agents on board, the tricyclic antidepressants and the gabapentinoids, because these are the only drugs that are effective once that modulation, sort of hijacking of the pain, of the acute pain pathway to chronic pain pathway starts to take place. Acetamin is not effective, opiates are not effective, nonsteroidals are not effective. At least acetamin and the nonsteroidals are likely not harmful, but really the opiates need to be weaned quickly, get them off, do not use opiates in chronic persistent surgical pain, neuropathic pain. Melatonin is particularly good in helping with the sleep disturbances and interrupting some of the pain cycle. We find that in children that if you don't get a good night's sleep, that poor sleep management exacerbates chronic pain. And think about it, if you get a crappy night's sleep, if you get a lousy night's sleep one night, and the next day, everything seems to kind of ache and pain and you're irritable. And if you get a great night's sleep, nothing bothers you. The same way with kids. If they get a good night's sleep, they're not going to focus on the pain. They're not going to be aware of it. And so if they're not sleeping because of pain, melatonin has been shown to be one of the most effective modulators of chronic pain in kids. And that gabapentin given at night also has sedating properties and can help with some of the sleep disturbances. I cannot overemphasize the need to wean opiates and not start opiates. In my profession, we like to apply trials of regional anesthesia to interrupt the neuropathic pain cycles. The data isn't great on the use of regional anesthesia, but the risk and the complication rate is so extraordinarily low that it's worth trying. A lot of focus for chronic pain has to be on physical therapy, strengthening exercises, massage, acupuncture, cognitive behavioral therapy, relaxation, hypnosis, and those kind of therapies are the therapies that are most effective once we've gotten into the chronic pain cycle. The real trick, and one of the things that I want to focus on as part of my research in the future, is how we can prevent this. Because once you're trying to treat it, you've already hijacked the pain circuits, you've already developed that chronic pain, and it becomes very, very refractory to therapy at that point. So the real sweet spot is going to be to try to identify the kids at risk and to prevent it and to intervene early. And so what I try to focus on is, find those kids. And we can tell a lot of times healthcare professionals, you can kind of look at a kid or a family unit during the preoperative evaluation, and you just sort of get this gut feeling that this is sort of, you just know who's going to have pain. They just sort of, you say, oh, that's a crazy family. That family is just crazy. And you can feel that. And rather than dismiss it and, sort of make a joke out of it, you have to say they need to be targeted in the postoperative period for additional intervention to keep an eye on it, calm them down, try to make sure that they're coping appropriately with the challenge presented by surgery. We have to make sure that we focus on effective postoperative pain management. When I talk about effective postoperative pain management, I have a t-shirt at home that has like opiate and like one of those big circles with a slash through it, like no opiates. Everybody knows I hate opiates, and I'm all of these, the American Society of Anesthesia, the Society for Pediatric Anesthesia, the World Health Organization, the European, all these different organizations say that the first therapy in any kind of acute new pain are non-steroidals, Tylenols, non-opiate containing multimodal therapy. The second layer is going to be regional anesthesia, and opiates are to be reserved as intermittent rescue therapies and not a first-line drug in anybody's hands. We're starting to talk about giving pre-op gabapentinoids to those kids who come to us already with chronic pain, those patients that we know have a high risk of chronic post-op pain, the scoliosis surgery kids, some of the kids having big orthopedic interventions. We're starting to study the use of preoperative gabapentinoid regimens. And one of the things I think that we're going to see in the future are acute pain clinics. Now, everyone has chronic pain clinics. We all know you can go to these chronic pain clinics and they'll stick needles in you and do things and, prescribe opiates and gabapentinoids. But by the time patients are getting referred to the chronic pain clinic, a lot of the pain process is already set in play and irreversible or on the way to becoming irreversible. So if we can identify those patients at the 5-day mark, who is still on opiates at 5 days, that flexion point in the risk, in the uptick of risk, if you will. If you can find those patients who are still getting opiates at 5 days, those patients who at their 1-month checkup are still having pain, those are red flags for risk factors. And we really need to develop functional acute pain clinics staffed with personnel who understand how to treat sort of the prolonged pain associated with acute pain. And this can be anesthesiologists, this can be surgeons, this can be PCPs, this can be pediatricians, but we don't have the workforce out there yet of people who understand this problem and are knowledgeable about how to intervene. So that is really an initiative that we need to start to undertake in the future. And I do like to emphasize that we need to be looking at the acute post-injury pain in the hospital setting. And so you would think that we would be responsible for making sure that our children are comfortable and not having pain while they're under our care in the hospital. And some of the most recent studies indicate that up to 44% of children are reporting moderate to severe pain in the hospital after admission. And what this was defined as is this was, there was a database, a data search that would go in and look at pain scores over the past 24 hours and pulled data out of the electronic medical record. And any child that had 2 or more pain scores registered as greater than 4 twice in the past 24 hours were flagged in this database. And this was where they came up with 44% of children. This was compared to only 17% of those patients, only 17% of those patients who were admitted for medical admissions. And 13% of these patients were still having severe to moderate pain on post-op day 4. The risk factors were teens, ICU admissions, and surgical patients. And so who are sort of the culprits? Who do we have to worry about? And the general surgery patients are some of the highest risk when you sort of break this out by surgical service. And we see that over 60 to 65% of those patients with moderate to severe pain are admitted under the general surgery service, 50% of plastic surgery patients, the neurosurgery patients are at 40%, ENT sitting here, and orthopedic surgery is actually only at about 35% of the patients having moderate to severe pain. Still, it's reprehensible, but this is the kind of work that we have to do in front of us. And this is the percent, this shows in that same study, the percentage of children with moderate to severe pain by admission date. And here's the patients on post-op day 0, post-op day 1, and here's out on post-op day 4. And so my conclusion for this part, there's a second part to this whole talk, but the chronic post-surgical pain is a neuropathic etiology. It's defined as pain lasting greater than 3 months. It occurs in 18 to 22% of children undergoing major surgery. We do have some identifiable risk factors so that we can predict who these kids are. We're starting to get a handle on this. Unfortunately, there are few resources available for pain management and support to these children and families after hospital discharge, and even fewer resources available to educate the medical healthcare workers in the perioperative period. And I think that the management of post-op pain is going to be one of the key things. I want to talk about, Sam talked a lot about opiate abuse disorder, and chronic persistent post-surgical pain is in fact different than post-op opiate abuse disorder. And chronic surgical persistent pain is a risk factor for opiate abuse disorder, but is not necessarily synonymous. Adolescents alone have a particular vulnerability to opiate addiction. And we unfortunately provide a gateway to them with opiate exposure in the postoperative period, even in the absence of the development of persistent chronic postoperative pain. And I want to be able to put a face on this problem. And this is a kid who came to us in our, this kid came to us a year and a half after his surgery, a year and a half, 2 years after his surgery. He had an ACL repair, typical anterior cruciate ligament surgery repair kid. You know, adolescent, sports injury, good kid, no exposure to opiates beforehand, comes to us, gets his knee fixed, and post-operatively we're giving him morphine and Dilaudid in the recovery room and prescribe him oxycodone post-op and send him home with, you know, your typical prescription for oxycodone. We think nothing of this. This is bread and butter for us. We do this, you know, 50 times a week. And this kid comes back to us 2 years later and says, I want to tell you my story because I want you to understand how you're exposing kids in the perioperative period, what the risk factors are, and I want you to have a face on this. This kid tells us that in the post-op period, he actually wasn't having a lot of post-operative pain, but in fact, he liked the way, he knew about opiates, and he was thinking about it when we were giving them to him, and he liked the way they made him feel. And he then exaggerated the degree of post-op pain he was having just so that we would continue to give him opiates. He continued to complain of pain, had his opiate prescriptions refilled long into the post-operative period, was then transitioned by him, he got away from legal prescriptions and started to go to purchasing drugs on the street via different suppliers. And at about a year and a half, he went to his mom, who was a nurse. They put him in rehab. He kicked the habit. And then we saw him 2 years later in our clinic just telling us about this. And this was really the first time I put a face on this and said, oh my God, are we actually doing this to kids? And in fact, he really brought this to home. And if you look at the statistics in 2017, 5.8% of our 8th graders in the United States of America have used illicit drugs other than marijuana. 5.8% of 8th graders, 9.4% of 10th graders, and 13.3% of 12th graders, other than marijuana. This is a frightening statistic to me. So why teens? What is it about teens? I mean, we roll our eyes and say, oh, these are, you know, these teenagers, this is just a teen. And in fact, teens are uniquely wired to become drug addicts. They're designed to take risks and learn to be rewarded from taking risks. They're extraordinarily fast learners by design. And the social pressures that we put around teens really, really makes them susceptible to opiate addiction. And so let's first talk about that behavior that we're all aware of when we kind of roll our eyes and wait for our kids to outgrow. And that's the incomplete connections between different parts of the brain. And we know that the teenagers, their behavior is heralded by poor impulse control, poor weighing of risks, high reward responses, and that they need higher doses of risk to get that same rush as adults. And this was, I don't know if I can, I don't think I can play this video. Yeah, I can't. But this is a video of a teenager. And you can see here, there's this, I think he's trying to impress this girl. He's on a motorbike in the water, going fast enough that it's elevating him. And this just sort of exemplifies the teen risk-taking behavior in my mind. And we see the brain connectivity in children develop over 20 years. And it develops from the back of the brain over to the front, over 20 years, and 25 to 30 years is what we're really seeing. And the brain isn't fully connected until age 25 in women and age 30 in men. And the brain connectivity is where we get our impulse control, and where we get the limbic system connected to the cortex. And why does this happen? What are the sort of Darwinian advantages of this kind of system? Well, teens need to take risks to become adults. If teens didn't take risks, we would all still be living in our parents' basements, because teens have to take risks. Think about this. You have to get out of the house and you have to go start a job. You have to leave home. You have to form relationships. And these are all very, very risky behaviors. And so here's this little tiny fish, trying to leave his nice little cozy fishbowl and enter the big bad world. And these are the kind of pressures that we're putting on teens, and we have to be able to give them the skills to do this. And we do reward risk for this reason. Now, unfortunately, the high from drugs plays right into this teenage system. And so the reward circuit is integral to the limbic system, and the reward circuit system, it responds. So if something is pleasurable and something makes you happy, then it releases dopamine. And we find that drugs actually release large amounts of dopamine, making kids feel good. And the dopamine actually teaches the brain to repeat activity. So when you get warm, when you're cold and you get warm, you release dopamine, like, now I'm warm. Or if you're hungry, a baby eats food when it's hungry, and then dopamine's released and the baby says, no, I'm not hungry anymore. And these are the kind of systems that we have to set up so kids can learn. And unfortunately, drugs release large amounts of dopamine, and the brain remembers. And dopamine reinforces the desire to use drugs. So why teens? They are the fastest learners you can even imagine. These synaptic connections of the brain, the ability of the synapses to change themselves, is called synaptic plasticity. And learning is just persistent changes. We see the synapses get together, they change, they say, oh yeah, this is how I learn, repeated stimulation. And by the way, don't ever challenge your teenager to like a game of memory. Those cards, you flip them over and you try to have to remember and match things up. The teenager will beat you every time. And the reason is that they can remember and learn faster where things are, because they have this synaptic plasticity. So the first time they get hit with something, it releases a few neurotransmitters, and they build up a couple of synaptic endings. And, you hit them 2, 3, 4 times with something, and they develop these newer and faster synapses. And teenagers have a better ability to form these new synapses more quickly and more strongly. And this is a graph showing synaptic learning over the lifespan. And you can see here that the children learn the fastest. And we see that in kids. We see language development. We see motor development. And teens right here are very, very strong synaptic learners. And the good news is here, look, we as adults, we're still learning. We still have the capability here. It's just not as strong as the teens. We're not reinforced as quickly, making us then a little bit more refractory to sort of, drug addiction. And drug addiction is a form of learning. And with these fast learners, the brain just learns in this reward system, and teens get addicted harder, stronger, and faster. And that's what makes them uniquely vulnerable. That, in addition, the last thing, in addition to being fast learners, are these social pressures that we put on our teens. And we know that kids sort of dare each other, smoking, drinking, sexual activity, and kids just want to fit in with society, and trying out these risky behaviors sort of can buy them into a club and gain approval. And this is an area where we as adults need to provide appropriate outlets for kids to be included to gain approval in ways that are healthier and aren't going to expose them to risks. So how does this play into the gateway of drugs in the perioperative period? And so so the real question is, what is the incidence of continued opiate use in an opiate naive patient presenting to the operating room after routine surgery? And this is the data specifically in children, and this is done by Chad Brummett and his group. He's the middle author here, and he always points out to me, he says, Karen, that's not even my study. I was only the middle author. So this was really Harbaugh's study, I suppose, but I give him credit for it. And this just shows persistent opiate use in pediatric patients after different surgeries. And these are patients who are all opiate naive coming into this. If you were on opiates or confessed to being, on opiates, then you were exempt from this study. And what he showed is appalling and really horrifying and dramatic to me. And this is a very emotional topic for me, because I think that I do this every single day on children. I expose them to surgery, and I had no idea that these were the numbers of at-risk patients. And so what we see here is after a colectomy, 15.2% of our children are still having their prescriptions filled at 6 to 12 months later. And this doesn't even imply chronic pain. It's just they're still using the opiates. After a supracondylar fracture. A supracondylar fracture is the most common fracture in children, and 7.4% of those are still having their prescription filled 6 to 12 months out. A simple gallbladder, whether it be laparoscopic or open, 7.3%. An epigastric hernia, simple epigastric hernia, 5%. Appendectomy, 5%. Tonsillectomy, 5%. Arthrodesis, 5%. Oh, laparoscopic hernia, 4% versus 5% for an open. But the bottom line is, if you look at this data, you can really say, gee, persistent opiate use, or by another name, opiate use disorder, is the most common complication of routine surgery in children. And this is something that really needs to be sort of underscored and understood by healthcare professionals taking care of kids. And this just shows that there's really no relation in the initial opiate dose prescribed and whether or not the kids go on to develop opiate use disorders. And so what can we do as healthcare professionals? The first thing to do is we need to understand the stakes. We need to understand that this problem is out there and understand who is vulnerable. And we need to understand that there are ways to avoid opiates using multimodal methods as prescribed by all of the major societies out there. We need to understand that most adolescents do succeed without serious problems. And what we really need to do is hone in and identify those patients who are not succeeding and who are at risk. And so the takeaway is that, and I'm going to blend my two themes here, the chronic post-surgical pain and the opiate abuse disorder, in sort of my take-home summary. The first is that surgery may result in chronic post-surgical pain in 18 to 22% of postoperative pediatric patients. It is neuropathic in origin and is refractory to opiate therapy. And to persist with unwarranted opiate prescribing only exacerbates the problem of opiate abuse disorder. The second take-home message is that even in the absence of chronic post-surgical pain, as the result of perceived acute postoperative pain, approximately, actually I have here 6% of adults, it's 4.8% of pediatric patients, whether it's a minor surgery or a major surgery, including third molar extractions, go on to refill opiate prescriptions 6 to 12 months out, and by definition is opiate abuse disorder. This increases, as Sam highlighted, that the probability of continued use of opiates increases dramatically on those patients who are still taking opiates on the 5th day of use. And again, that take-home message that we have to treat pain aggressively with a multimodal opiate-sparing regimen and identify those patient populations at risk and develop safety nets to take care of them. And that is where we need to be putting our resources. I always like to have questions in an interactive session. This was Sam's slide. And I want to I don't want to end like with all this pessimism, like, oh, this horrible, what can we do, doom and gloom. You know, the boat really hasn't sailed on us yet. You know, oh crap, was that today? No, it's not today. You know, let's not make it today. Let's not let the boat sail on us. Let's do something. Let's educate. Let's be aware of the problem. Let's get rid of the opiates and move forward so that we can have healthy kids. And there are a lot of groups out there trying to do this, the Choose Wisely, Gen Wise program here with the intervention today with this lecture, the Improving Wisely initiatives. And there are a lot of people out there that are taking this seriously and can strengthen the effort to address these problems. And with that sort of last stand on my bandstand, I want to thank everybody for attending this lecture, and I'd be happy to have any kind of questions addressed. Just email me and I can answer questions and help you at any time. So thanks.